procedure that we are going to demonstrate now is known as the tracheostomy. Tracheostomy is an operation in which we make a hole in the trachea, and this hole is made at the level of the third and fourth tracheal ring. As before embarking on the procedure, it's always better to get an X-ray of the neck done to see the position of the trachea. The position of the patient is that the patient is lying supine on his back with a sandbag under the shoulders. As with any surgical procedure, before giving the incision, the area is cleaned. After cleaning the area, we identify the surgical landmarks. There you can see a simulation of the thyroid cartilage is given here, and at the lower end you can see the suprasternal notch. For the beginners, it's always better to work in the midline and give a vertical incision. For people who do a regular tracheostomies, it's better to take the horizontal incision. Before starting the procedure, it's always better to give local anesthesia. The local anesthesia is given in the consideration of 1:2 lakhs xylocaine with Adline. The advantage of putting Adline here is that first of all, it will delay the absorption of xylocaine. 2, it will cause vasoconstriction. A vertical incision is given from just below the thyroid prominence going towards the suprasternal notch. We apply traction on both sides. Then we start the incision, starting from just below the thyroid prominence and extending down towards the suprasternal notch. The ideal incision can be between 3 to 4 centimeters, but if needed, this incision can be extended downwards as well. After giving the incision, we secure hemostasis. After securing hemostasis, we dissect. We dissect the soft tissues of the neck and the strap muscles which are lying in the midline. Once we have dissected the soft tissue and the strap muscles, we apply retractors on both the sides. After applying these retractors, we try to identify the trachea. At the level of the second, third, and fourth tracheal ring, we encounter the thyroid isthmus. We dissect the thyroid isthmus and we retract it either upwards or downwards. After retracting the thyroid isthmus, we can see the tracheal rings. What we do is, first of all, we confirm these tracheal rings by feeling it with our finger. We can feel the tracheal cartilage. Then, to confirm it, what we do is we take a syringe filled either with normal saline or xylocaine. We inject a small part of the syringe inside, and then we draw. Once we draw, we can see the air bubbles. As trachea is a cavity which is filled with air, the air comes in the syringe and the air bubbles can be seen. After identifying the trachea, then we give the incision. The incisions can be temporary and permanent. Here we'll demonstrate the temporary incision. It's a H-shaped incision. The incision is given in between the third and fourth tracheal ring. After giving this incision is extended, as you can see, on the lateral sides. On the lateral side, this incision goes upwards and downwards. Upwards and downwards on both the sides, making it like a simulation of H. There you can see incision, straight incision, then on the lateral side incision extended upwards and downwards. This is a metallic type of a tracheostomy tube which is going to be inserted here. These metallic tubes are usually inserted for long-term periods. We have given the incision in the trachea. Now we take this tube and we have put the tube inside the trachea. You can see this